Hello, everyone. Thank you for attending the joint meeting with ESGE delegates, electronic TEP. We welcome two professors from Europe, Professor Esteban Hertz and Professor Thomas Hackel from Hungary, and Esteban Hertz from Hungary, and Thomas from Czech Republic. We have two communication, management of biliary stones and management of colorectal polyps. I see Esteban, and is Thomas here?
Good afternoon, this is István here speaking from Budapest, Hungary, and I just spoke with Thomas Hutzel. Hello, Sarak, can you hear me?
You start?
Hello, Sarak, can you hear me?
Okay, we start by management of colorectal polyps, Dr. Esteban Hertz from Hungary.
Oh, thank you. So this is what I...
دكتور علي فرج، دكتور هشام قطان، هاني شهاب، ايمن يسري، احمد هاشم and Khalid Siraj. Please start.
Good afternoon, this is István Ritz speaking from Budapest, Hungary, and I hope that you can hear me. Okay, unfortunately, Thomas Hutzel from Prague, he has problems to join, so I just spoke with him on cell phone, and hopefully he will be able to join later on, okay? So,
we need to raise the voice, please, or adjust your mic, because we don't hear well.
In this case, because it usually worked very well, I will use my headphones. So,
better.
دكتور سراج.
Just give me a second, please, and I will try.
دكتور سراج.
Yes, sir.
أنا سامعه كويس.
لا هنا we don't.
ما أنا عشان كده بقول لحضرتك يمكن العيب عندكم، أنا سامعه كويس قوي.
لا أنا سامعك أنت كويس قوي.
وأنا سامع الراجل كويس قوي، فأنا بكلمك عشان كده لحسن يكون لحسن يكون العيب في التوصيل عندكم أو في حاجة. سامعه كويس قوي يعني.
صوت واصل عندي كويس.
Would you try again, Esteban?
Can you hear me right now?
Yes.
Yeah, we can hear you. We can hear you very clearly.
Much better, sir.
Okay, so because I just changed to my to my head microphone. So once again, good afternoon to everybody, and I hope that Thomas Hutzel will be able also to join. Unfortunately, he has some technical problems right now. So thank you for the kind introduction from Professor Serag Zakaria. Thank you for the kind invitation from the Egyptian Society, and I'm very honored, and it's my pleasure to be a participant from the part of ESGE. So my topic for today is the management of colorectal polyps, and what is my advantage, what I can tell you, and what you can see on my first slide, that I come from it's a double department. It's just recently developed. We started, it's the first department of surgery and interventional gastroenterology. It used to be first department of surgery, but now we have our totally autonomy unit with GI, and this is mostly interventional GI. So I can tell you, and I will most probably able to talk about the advantages with living together with the surgeons in one building. So, okay, I hope that I will be able. Okay, so what is very important, and why do we speak about the colorectal polyps? And why the colonoscopy as the gold standard? Because colonoscopy and the endoscopic treatment of the polyps, neoplastic polyps, play an important role in colorectal cancer prevention. And The recent advantages and in endoscopic imaging and quality standards have led to an increasing polyp and adenoma detection rate in the past 10 years. The optimal polyp resection techniques, it can be polypectomy, mucosectomy, as well as the endoscopic submucosal dissection, and management strategies are the mainstay for an effective colonoscopy practice. If we look at the whole endoscopy unit and one room, now what we can see that we have whole kind of instruments and accessories. And now what we use, everybody uses worldwide the video endoscopy and digital recording endoscopy systems, what gives us together the imaging. Thomas is going to talk about the bile duct stone management, where we have one another more modality, the X-ray, the fluoroscopy, which comes into the picture. And when we do the interventional endoscopic ultrasonography interventions and procedures, we have three modalities what we combine. So this is a very nice thing that we do minimally invasive interventions, combining different imaging modalities. But now what we are going to focus on is the imaging modality which gives us the endoscope. What are those benefits that we can now appreciate when we have the new types of endoscopes? The first is the early diagnostic, because now we can increase the rate of the detection, the early recognition of the the diminutive polyps, as well as we can reduct and decrease the adenoma missed rate. We can assess by the pit pattern and by the morphology of the penetration depth and rate of submucosal infiltration of the potential malignant changes, just by looking through the endoscope with different kind of sophisticated methods. We can use optical biopsy, which can replace targeted biopsy in some kind of settings, and the in vivo histological analysis and prognostication of presence of adenoma dysplasia and neoplasia sequence gives us a nice challenge for our work. So when we look first in the middle, what you can see here, this is just a white light. But when we use the high resolution, high definition endoscopy, as well as the zoom endoscopy, we can see that this small polyp, after we can see the morphology, the structure, even nicer. If we combine it with chromoendoscopy, and this is indigo carmine with zoom chromoendoscopy, you can actually see the surface of the polyps. So this is 5 times and 15 times zoom. We have, however, you know, the chromoendoscopy is now used mostly and widely replaced by the virtual chromoendoscopy. And from the Olympus, what we have in our hands is the narrowband imaging. I don't want to talk about it, but on base of different wavelengths and the penetration of different wavelengths into the mucosa, by filtering the wavelengths, we can get a nice denilated morphology of the polyps. This is what you can see on MBI. This is a white light, and this is the NBI. When we go closer, you can nicely see the structure of the sessile polyp. Just very briefly, we have some sophisticated methods what we can use also for detection and differentiation between neoplastic and non-neoplastic polyps. And this is one of them is the fluorescence endoscopy. When we use the fluorescent tissue fluorophores, giving to the patient a day before or 12 hours before and after using a fluorescence imaging by excitation light, it gives a fluorescent light which comes out from the surface, which is detected, and by different filters we can actually have a nice picture, and we can make a differentiation between the neoplastic and non-neoplastic polyps. However, this is esophagus, and this is the Barrett neoplasia. This is a nice but very sophisticated motif. This is the endoscopic laser scanning confocal microscopy. When the picture of the laser scanning microscopy gives us almost the same picture as on the histological slide. So by using this technique in the large bowel in the colon, this is the normal endoscopy, 30 times increase. This is the zoom endoscopy, 100 times. And when we look at this, you can see here the small rounded shape crypts on this picture, as well as here. You can actually nicely see as the histological slide the crypts in the colon. And one more modality, which is into the layers, the layers of the wall. It can distinguish between the mucosa, the muscularis mucosa, the submucosal layer, and the muscular layer, as well as the serosa. So in case of the penetration, looking at the penetration and infiltration of different precancerous or cancerous lesions, the neoplastic lesions, this modality gives us a very nice picture of the infiltration. So altogether, what we are using and what we like to come into the conclusion and summary of the detection of the polyps. So we are using the morphology, just looking at the polyp by using different classifications, starting with the Kudo pit pattern classification, or we can use the Paris classification or the NICE classification, which is somehow the most easiest classification. What is our goal and focus? To make difference and to differentiate between the neoplastic and the non-neoplastic polyps, and why it is important for us as minimally invasive endoscopists that we can remove these polyps. And just removing a neoplastic polyp without infiltration, this is RNU resection, and this is a therapy management of the polyps. I just don't want to go into details, but we have very nice ESG guidelines updated during the recent year or the last year about the imaging and detection of the colorectal neoplasia, the surveillance, as well as the post-polypectomy surveillance. So I just highlight on this. So they are available full text on the ESG website. So when we come to the main topic of my talk, my lecture, is the management itself, the minimally invasive endoscopic treatment of the colorectal neoplasia. So the aim is the complete removal of the RNU resection in case of polypectomy. Endoscopic removal depends on, of course, the size of the polyp, the localization between the haustra or in the curve just behind the fold. It depends on the skill of the endoscopist and, of course, the available techniques. It's about the endoscope as well as the different kind of manipulation and snares and so on. And this is what I would like to highlight, that collaboration with surgeons is very, very important, and it's key that sometimes the surgeons are asking us to do in kind of polymorbid patient when it's unfit for surgery to do minimally invasive intervention, as well as we may ask the surgeons to give us a background to do it sometimes in the OR, different kind of EMRs or ESDs in really high risk settings. The conventional technique of the polypectomy, the standard when we use a polypectomy snare, when we put a snare just below the polyp on the healthy stalk, and we do the resection, we may inject submucosal fluid to do the elevation, the lifting of this semi-sessile polyp, or we can use different kind of snares. I'm not going to talk about the piecemeal polypectomy, but we have to keep in mind that in piecemeal polypectomy, the RNU resection is questionable. And with respect to the oncology, we have to be careful that in this case, the patient should be, I'm sorry. In this case, in these settings, the patient should be carefully surveilled. The first thing, when we have the diminutive polyps, I don't know if you can hear me. I'm sorry.
We hear you, but someone is opening his mic.
Okay, so I will continue. So for the small polyps in size less than 10 millimeters or the diminutive polyps, we may use the one of the easiest way to remove the polyps is the cold snare polypectomy, which is superior to the biopsy forceps removal of the polyps. And what you can see here on this video, when we use the NBI, it's nicely seen that this is a neoplastic. It's a nice two classified polyp. And what we do is we take the cold snare, and with the cold snare, we just put it around the polyp. The first, we just grabbed a little bit more of the mucosa, what we wanted. For the second, we just asked the nurse just to close the snare, and without coagulation, without the endocut, without any kind of electrocoagulation, we remove these small polyps. We may see some blood. We remove the polyp as the first, and after the option, we may remove this polyp through the channel, or we can remove the scope. And you can see that this is also a nice tool what we have in this in our scopes, that we have the water jet system. And on the water jet system, by using cold water, we may see that after cold snare polypectomy, there is no bleeding and there is no resection of this polyp. So the surrounding mucosa and also the submucosa can be seen on this video. However, if we have a large polyps, what we can do in the setting of the large polyps with a very short stalk. So this is what we can see. This is a huge tubulovillous adenoma, and the patient was unfit for surgery. So we decided, even in high-risk patient, to do the cold snare. And what you can see, this polyp was more than 3.5 centimeter big. This is a tip and trick that we use the huge oval polypectomy snare. So by jiggling the scope, by positioning, by inflating, and by deflating CO2, of course we do CO2 in all our colonoscopies at intervention, we try to get this snare, you can see here, around the polyp, because the stalk would be around 4 to 5 o'clock position. And now what you can see here, we were able to, with the jiggling movements, the snare is around the head of the polyp. And you can see here, you can appreciate there is a short stalk. And what I jiggle, advance, push and pull to make sure that we didn't grab any kind of fold and any kind of adjustive tissue just behind the polyp. And so we start the endocut. We call the electrocoagulation, which is like a blended current with coagulation as well as cutting mode. And we remove the polyp with the same snare. By removing the endoscope from the sigmoid, remove this quite huge. And this is the end picture, because we had some bleeding. It was Arno resection, and we closed the we closed this small submucosal injury with clips, as well as we had 2 oozing bleedings. We managed them with these hemoclips. In case when we have a thick stalk, and I have to admit that this is a hyperplastic from the stomach, but I would like to just highlight on the advantage of using the endoloop. What is the most important? These hyperplastic polyps, usually they are not neoplastic, so they don't turn into invasive carcinoma. However, these may bleed, and unfortunately they get bigger and bigger, and sometimes they just occlude the antral channel as well as in the pylorus, so they may cause some obstruction. So these polyps have to be removed, regardless that the recurrence rate is quite high. So what we use in this case, when we have a thick stalk, just to prevent bleeding, we can even put a endoloop as close to the normal surface as far as we can from the polyp, and after resect it with a snare. However, if the situation is different, and in the colon, when we can see also again a thick stalk and a quite big polyp, here. And because of the endoloop itself, the line sometimes is very long and gets into the picture and into the vision. So sometimes I don't like it in the colon. What we can use to use the hemoclip, and with the hemoclip, we can actually prevent the bleeding. Before we remove the polyp, we just put the hemoclip on the stalk. So you will see that this is a positioning of the clip as close to the lumen, to the wall, and by placing the clip, you see the clip is a quite long clip, and after it's an easy way just to put the snare just around the head of the polyp and to make sure that to resect it between the hemoclip and the polyp. We have to make sure that the first, when it gets into the connection with the clip, we are not able to cut it out. So in that case, you have to take it into consideration to get close, to go a little bit closer to the polyp. And you see that the resection has been done. This is the stalk, and this is the polyp, which can be removed by the polypectomy snare. In case when we have a sessile polyp, and we would like to use the minimally invasive techniques, the endoscopic mucosal resection has been firstly described. It was more than 35 years from now. 4 basic techniques are available and are used worldwide. The inject and cut, the submucosal lifting, and after cutting and removing by a snare. This is the easiest way to do. However, when a double channel endoscope, we can first place the snare around the lesion after grabbing the lesion with a biopsy forceps or a foreign body forceps to pull it and to snare it. Or we can use the cap-assisted EMR, the EMRC, when we place and pull into the cap. Actually, we suck it into the cap and do the removal, or we can do the band ligation device when we put the ligand, and we can snare it below or under or behind the polyp. So the advantages of the EMR is it's very simple, it's easy to learn, there is no time consuming and safe technique. The removal of flat or sessile lesions between 15 to 20 millimeters. However, the limitation is that removal of more than 2 centimeters lesions can be sometimes only by piecemeal technique, and this is suboptimal in terms of histopathological staging. We don't know sometimes if it's R0 or R1 resection, and it's also suboptimal in terms of oncological assessment. So the risk of local recurrence when we do piecemeal resection is higher than we do R0 resection. And in this case, I would like to show, this was a patient with 3 different polyps. It was with a long stalk. We removed it and also placed some clips. And this polyp, if you look at it, there is a polyp and there is a morphological sign of neoplasia. So what we started first, we injected, we lifted the mucosa first behind, because if we start from the front of the polyp, sometimes we may actually bury the polyp just behind the fold. So we start usually the injection from behind the polyp, from behind the fold, and afterwards we are able to lift up the polyp with the injection needle. So we see this is a nice lifting sign. Even the sign and even the morphology of the polyp was showing us maybe some mucosal infiltration, but in this case we were able to be able to remove, and we just placing the snare just below the polyp in the submucosal area, and by gentle cutting this patient, the thrombocyte, the platelet level was quite low. We were not able to get more than 80 of the thrombocyte level, so we were doing very so after cutting just the last part here, and we can see here this nice bluish, when what we usually mix the saline with some methylene blue, and after remove the polyp with a snare. And it's very important all the time when we remove the polyp just to go back and to see the battlefield, as we call it. So we get rid of the polyp, and when we go back, this is a nice polypectomy wound. But what we can see in the middle, it's a pulsing vessel here. So normally, if there was no vessel there, I would just leave this, and I wouldn't put any clip on that. But in this case, we have to manage this to come across and to prevent the post-mucosectomy bleeding. So we are using the reloadable clips from the Olympus. So we are placing the first clip usually in the middle, and after, if it's needed, on the two sides, we also place some clips. So it was the first clip. And afterwards, I decided to put another clip just below it, because there is the part of this vessel there still. Positioning and these small movements are very important in case of polypectomy, and it's a nice teamwork between the doctor, the endoscopist, and the nurse, the assistant. And usually before shooting, I apply suction, and it's nicely, the wound is nicely closed. In case of even bigger polyps, sessile polyps, where in diameter more than 2 centimeters, the en bloc resection can be obtained by using the endoscopic minimally invasive surgical procedure, which is called endoscopic submucosal dissection, the ESD, which has been described more than 20 years ago by Yamamoto. And briefly, the technique, the lesion, the marking the lesion all around with coagulation, and after doing the lifting, and different kind of procedures and different kind of suggestions in case of different polyps. We may cut it all around, the whole lesion all around, or we may just make a small pocket. But what is very important, just marking, lifting, and after doing cutting, and after getting with a unique oblique cap attached to the end of the tip of the scope to get into the submucosal area and to do the dissection just below the lesion, and be able to do the dissection of the whole polyp. And this can be finished by loop snaring, by snaring, and it's called the hybrid EMR or hybrid ESD, or finish the whole thing with the knives. For this sophisticated method, we have available different kind of knives and also different kinds of caps which can be attached to the scope. The advantages: it's a well-established technique already for en bloc removal of large and potentially deeper subepithelial lesions, sometimes also in SM1 and also in SM2. The rate of curative Arnoux resection is higher. The limitation, what we have to take into consideration, that it's accessory and time consuming. It's a complicated method. The tools are quite expensive and needs special training. It also needs theory and practice. It needs practice in ex vivo models, also in vivo animal models, and also in humans. So the learning curve is quite long. It takes time, and the complication rate, even in experienced hands, is higher in terms of bleeding and perforation. in our hands in Hungary and Europe, we don't have so many early gastric neoplasia. What we have and what we usually use in our department is the ESD of the rectum. We may replace it, or we may combine this technique together with the transanal mucosectomy. So what we do the marking, the lesion all around after injection and cutting, and after doing the submucosal dissection, and by removing, we use the clips for closing, not closing, but preventing the bleeding in this case. In summary, the focus for the colorectal polyp management is to use the proper endoscopic techniques for imaging to detect the polyps, and in terms of therapy to attempt complete removal, as well as prevent and to reduce the post-polypectomy complications, means perforation and bleeding. I thank you for your attention.
Thank you very, very much. It's a lovely presentation. This is Dr. Hani Shahab with you. We thoroughly enjoyed it. It's a huge topic, and it's very nice to summarize it in this presentation. I have a comment. Yes, over the last decade, there was been this enthusiasm for the ESD, and everyone was rushing, trying to copy the Japanese and Chinese in doing ESD more and more. But I think especially in Europe, there have been recently many studies trying to focus back on EMR. And many are saying, you really don't have to go through all this hassle of an ESD, because EMR can perform almost as good. So my attitude toward this is, if the lesion is, you can grasp it within a snare. I mean, if it is within 2 centimeters, then I still favor an EMR. Do you think the same?
Yes, I completely agree. Thank you. Yes.
Well, I'd like to ask a question. Thank you for your presentation. Do you think with those advanced imaging techniques now, you still have to do a biopsy, or how frequent do you do a biopsy now?
Yes, I'm sorry. Any part of the question, or
how frequent do you do biopsy now with these advanced endoscopic imaging techniques?
If it's a small polyp and the patient is outpatient, and we know that we can remove the polyp because the patient is fit for removal, the patient has the recent lab test in terms of blood count and the prothrombin levels, and the patient is not taking any kind of anticoagulant treatment, we do it right away without taking any kind of a biopsy. In terms of when it's a huge polyp, which needs definitely inpatient care, so we have to sometimes do the elective procedure, and the patient needs to be scheduled for that. We usually take a biopsy. So yes and no. So these techniques, what is now, we have a policy in Hungary still that each and every removed part of the body, if it's a polyp, and even if we think that it's a non-neoplastic, hyperplastic polyp, we cannot do the resect and discard technology, what is already described in nice papers and publications, because the policy is when you resect something, you have to send it to histopathology. But the question, answering your questions, with the optical biopsy, we may actually differentiate between the neoplastic and non-neoplastic lesions.
So just I have a question regarding assessment of the submucosal invasion. If the polyp, apart from lifting, is there any sign to assess for submucosal penetration in big polyps?
I don't know which kind of classification are you using. So let me answer your question by another question. So it's the question about the assessment of the polyp and assessment of the, I would say, the worrisome features. definitely, which gives us the best I'm sorry, the best result in terms of being able to remove it is the lifting sign. If there is no lifting sign, definitely we are not able to remove it. But the non-lifting sign can be due to the scars, or can be due to the invasion. So sometimes you are not able to make sure and make difference if it's invasion or just a scar. In that case, if it's in the rectum, we may use the endoscopic ultrasonography to see the layers and to definitely see nicely the layers and to see if there is any kind of submucosal invasion. But most probably in those in this kind of the classification methods, the pit pattern of the polyp gives us sometimes the very important feature if the patient, if that polyp has a submucosal infiltration or not.
I have two quick questions for you, Esteban. First of all, which patient would you do for him the full thickness resection? And the second question is, are there any non-cancerous polyps that you still send to the surgeon?
Yes. Okay. I'm replying the first question. I didn't put any videos in the full thickness. The full thickness, I would say, if we had Germans here from the group of Professor Zaya, definitely they would have much more experience also in the subepithelial lesions. We used a couple of times. I didn't do more than 3-4 full thickness resection with the FTRD device. And I used it only in those cases when it was already a polyp removal, and we had the scar, or we had the new polyp, or some polyp remaining on that. So we used this for the indication of these polyps were for EFTR. Or in those cases when the patient is unfit for surgery, so the patient would not be operated, and it's neoplastic lesion, so it's not just high-grade dysplasia, but it's in situ cancer. The surgeons sometimes ask us to do it and to remove it with the EFTR. But in that case, we have to make sure that the lesion is not bigger than 2 centimeters to have a nice result. And yes, in some cases, when we are not able to remove, I would say, if we risk the patient and we have to weigh out what is the risk for the patient for the penetration in terms of penetration. If it's a huge sessile cecal polyp, which is low-grade dysplasia, and we are not able to just get behind the Bauhin valve, the ileocecal valve, we may ask the surgeons to do the laparoscopic right hemicolectomy, which is not so high risky for the patient.
Dr. Hani, can I ask something?
Of course, please go ahead.
Okay, it's very nice lecture. Thank you very much. But I have 2 comments. First, using the reusable or the reloadable clips, it's very difficult to use. And just to have one applied, we usually use 3. Why don't you use those you can open and close every time?
It's very, very, very easy answer. It's because of the money. Because these reloadable clips cost us, like, I would say, 15 euros. And those ones that you can be open and close and open the close and after just to shot, it's like 150. So this is a big difference. And that's why in that case, if it's a straight situation, and you could see in this mucosectomy when I closed the wound and also prevented the bleeding, in that case, everything was straight. The scope was straight, so I didn't have any kind of a hassle to place those clips. So I decided for the cheap clips.
Yeah. My second comment is that I saw you closing the opening with a central clip in the beginning, and then you go to the sides. I think if you go from one side and you go through, it will be much easier, just like the way you are doing in Point.
And this is also nice doing this. This is about the practice, how you do it. You can do from the side and doing it like step by step. In that case, this is what I also said, that I wouldn't close that wound if there was no vessel in the middle of that wound. So I just used the clips because of the prevention of the bleeding. So that's why, because it was quite in the middle, I placed the first clip in the middle. And after I saw that there was some place to put more clip, because the vessel was still not closed. So that's why I used the second clip. But you are right. You can close the closure as usually as the poem from the side, as like doing a zip technique. In this case, I used a different technique.
Thank you.
Would you use other methods of hemostasis like the coag forceps or maybe APC, or you prefer the clips?
I don't like the APC. The APC I just use when I do the piecemeal mucosectomy technique, and I do the APC just around the lesion. Even if I don't see any kind of a tissue remnant of the polyp, sometimes I do all around with the APC, the coagulation of the polypectomy wound. I like the spray coag, very nice, because the spray coag is very easy to use, because you don't have to actually change your tool. Even with the snare, if you just open a little bit the snare, if you ask the assistant just to come up with the tip of the snare, you can nicely do the spray coagulation. You have to be very careful when you do force coagulation. You shouldn't do it with the tip of the snare, but with the spray coagulation you can use it. I don't know if you have any kind of experience with the Purastat. The Purastat, this is a solution which can be used like the hemospray. So it's a tissue adhesive.
Spray, yes. Yeah.
Yes, but it's not a spray. It's a solution. It's a quite viscous solution what you can put, and it's nicely those kind of oozing bleedings after the polypectomies and mucosectomies. It's nicely closes and stops the bleeding.
And how much does it cost, the Purastat, one application?
Oh, it's quite expensive. I cannot tell you from the top of my head, but it's expensive.
Okay.
Thank you very much, Esteban. It was a lovely discussion and presentation.
Thank you.
We'll shift now to Professor Thomas Hook from Czech Republic, who will give us a presentation on the management of biliary stones. Professor Hook.
Hi, can you hear me?
Yes.
Well,
I'm very sorry for the technical difficulties that I had in the beginning. I would like to thank you for your understanding. And
no
I would like to, one more time, thank you, the organizers, for the invitation. It's always a pleasure to be with you in Egypt. So the topic of my talk today is common bile duct stones. Can you please see my presentation?
Yes.
Okay, so common bile duct stones are not that infrequent. We actually see them quite frequently, and they may develop primarily in the bile duct, but that is less frequent. And more frequently, they develop. They actually get to the bile duct from the gallbladder. Those stones we call secondary common bile duct stones, and they migrate from the gallbladder via the cystic duct into the common bile duct. They occur in about 10 to 20% of patients who have symptomatic gallstones, and in less than 5% of patients who have who go for cholecystectomy, where there is even no clinical suspicion that they have stones. Bile duct stones may be asymptomatic, but they may cause some symptoms. It may just be pain. They may cause biliary obstruction, infection, that is cholangitis. That may also result in an hepatic abscess. They may eventually cause, if they are present for a long time, secondary biliary cirrhosis. And also they can cause acute pancreatitis. So for my talk, I actually, as guidance, I used two recent guidelines, a little older one from the British Society. It's an update of their older guideline, and this one is from 2017, and then a more recent guideline from the ESGE. So if we have symptomatic CVD stones, we always treat them. But we also treat patients who have CVD stones and do not have any symptoms. And we do have some evidence. We do not have any prospective randomized data that we would have patients who have CVD stones and we would divide them into two groups and see what happens. But we do have some retrospective data, and that's the goal risk study, where they looked at a quite large group of patients who had CVD stones. And they either were treated conservatively, so did not have any intervention, or they had a stone removal. And you can see that the unfavorable outcomes, so symptoms, actually occurred in this group of patients who were treated conservatively much more frequently than in those who were treated for their stones. So when we do treat our patients if they have gallstones, no matter if they do have symptoms or not, because symptoms may occur later. The two basic tests that we have to evaluate for the presence of CVD stones are transabdominal ultrasound and liver function tests, and they do actually pretty well. They are not perfect, but they do pretty well, and you see some sensitivity here. So if you have a decent pretest probability and do an ultrasound, you have a very high chance of having having a stone if you see it on the ultrasound, and the same is for ALP. What is important to remember is that if you have normal results, it doesn't mean that you do not have bile duct stones present. So if there is a significant clinical suspicion, you need to further investigate. So there are two other more advanced techniques that you can apply to your patients. One is not invasive, that's MRCP, and one is invasive, and that is EUS, and they actually perform very well to detect CVD stones, and they perform pretty much the same. So you see that the results are roughly the same, and the selection depends on the local situation, local availability, the patient's preference. MRCP, again, is a non-invasive technique, whereas EUS is an invasive technique. I think one good thing nowadays about doing EUS for CVD stones is that you can do an EUS and do at one time ERCP in case you find a stone. That will save the patient from having another having another procedure. Some patients have a CT for detection of CVD stone, or for some other reason, and accidentally we find a CVD stone, and a CT does not do as well as MRCP or EUS, but still it's a pretty decent, and often we do CT in case of biliary obstruction to rule out malignancy. So when do we apply these different tests? So if we have a suspicion of a CVD stone, we will always do liver function tests and ultrasound, and then we can stratify. This is one algorithm. There are more algorithms, but this one is, but they are actually quite similar. And so after having abdominal ultrasound and LFTs, we can divide our patients depending on the risk of having a stone. So if the risk is very high, so we do see a stone on abdominal ultrasound, we don't need to do any further examination. We proceed to ERCP. If the risk is very low and we don't really find much suspicion of having a stone, we just will look for another diagnosis and will not proceed this way further. And if the risk is intermediate, we are not sure, that's actually the place for endoscopic ultrasound or MRCP. Depending on the result of these two examinations, we either move to ERCP, proceed with ERCP, or investigate further for other causes. So ERCP is the method of choice of removing CVD stones. The efficiency of ERCP is very, very high. There is actually, for example, this ESGE state guideline, which says that if you have a stone that is smaller than 10 millimeters, you should be able to achieve bile duct clearance in 90% of the cases. That said, that is telling us that the efficiency is very high, and it's definitely greater than 90% in one procedure for smaller stones. It may be different for larger stones. We'll get to that later. There are basically two techniques that you can apply to remove a stone from the bile duct. Now speaking about the very removal one, from the bile duct, and after sphincterotomy or balloon sphincteroplasty, we'll talk about those later. You then go for your stone into the bile duct, and you can either use a basket or you can use a balloon. And there's just an example of several different balloon extraction balloons here that are produced by different companies, and they come at different sizes. You know, here we see an example of different baskets, and they may come again. They may have different sizes, but they may also have different shape. Some of the wire baskets can be introduced into the bile duct over a wire, which may be good if there is difficult access. And when it comes to balloons, they are always introduced over a wire, and they also have different sizes. Some of the balloons nowadays, like the one from Olympus, can be inflated. Just one balloon inflated and into 3 different sizes, which then is convenient. And I think the two techniques have advantages and disadvantages, and every endoscopist should be familiar with both of the techniques or both of the devices. Maybe we'll come to this in the discussion again later. There is some data, of course, and this is just naturally understood, that in difficult cases, it is of advantage to have anesthesia, either propofol, general anesthesia for your patient. And for a simple stone, at least in the part of the world where I come from, we generally do not use that, and we just use conscious sedation. But if you have a complex procedure, then definitely this will be of advantage for the patient, but also for you as an endoscopist, and your chances definitely will go greater. And this is what is said in this sentence. And patients sometimes we administer antibiotics to our patients. I think when it comes to CVD stones, we would do this. We would do it. Of course, if there is already a cholangitis ongoing, then we will treat our patient with antibiotics. And then another indication would be if there is obstruction that we are during our ERCP not able to fix. So then our patients need to get cholangitis, that's this failed attempt to drain. In the pancreatitis, post-ERCP pancreatitis should be prevented in all of our patients, and we generally do require that patients will have their full blood count and INR investigation, usually within 3 days or 1 week prior to ERCP if we plan to do sphincterotomy. And if there is some abnormality, or if our patients are on some vitamin K antagonist or some other drugs, then we would manage this according to the recommendations. There is we already mentioned sphincterotomy. So to be able to remove a stone, we need to get good access to the bile duct, and we need to perform a sphincterotomy. So that's the basic technique. Apart from doing a sphincterotomy, we have another option, and that is doing a balloon dilation, endoscopic balloon dilation. And that is a technique that is strongly recommended to remove large stones, because to remove large stones, this technique may be of advantage and may make it easier to remove these large stones. When we talk about large stones, we talk about stones that are larger than 10 millimeters. There is some evidence that says that if you do endoscopic balloon dilation of the papilla, your chances of getting acute pancreatitis may be greater. At least for the purpose of these two guidelines that I mentioned, this is still appreciated, and therefore it is recommended that when we do biliary balloon papillary dilation, we do first a sphincterotomy, a small sphincterotomy that we follow with balloon dilation. There is also a lot of data, recent data, that say that this is actually not needed and that the risk of pancreatitis is not increased, and that this data suggests that balloon dilation may be done without sphincterotomy. I think we'll go into this here. So you can also use a small balloon. For a small stone, you can use a small balloon, balloon that is below 10 millimeters, and this you can do without a sphincterotomy. And I think most people, for a small stone with a non-dilated duct, will not really use a balloon dilation. I will proceed with sphincterotomy and stone removal. This can be used in patients who have coagulopathy, because there the chances of bleeding are smaller. And then we come to large balloon dilation. Sometimes it's called EPLBD, for large balloon dilations, and we use this if we have large stones. And we have data that this will facilitate stone removal. It will decrease our need for mechanical lithotripsy, and we'll be able to remove our stones more easily. So again, with or without sphincterotomy should have same success rate. We already said that some studies reported no increased risk of pancreatitis if you omit sphincterotomy. So some people will, especially in Asia, proceed without sphincterotomy. When you do this, you should not, you choose your balloon first. So you should dilate to a diameter that is not greater than the diameter of the CBD that is dilated above the papilla. And I don't think we ever proceed to a larger diameter than 18. You should inflate slowly, as you should always do when you do any balloon dilation anywhere in the GI tract, and wait for the waist, which is at the level of the papilla, to disappear. It is recommended, I don't think there's much data for this, that you should dilate for like 30 to 60 seconds after the waist disappears. That means that you open the papilla. The presence of periampullary diverticulum seems not to increase risk of adverse events. What does increase risk of adverse events is a stricture at the distal CBD. So we generally do not do balloon dilation if there is a stricture. And apart from coagulopathy that I already mentioned, where this can be of advantage, it can also be advantages in, for example, ERCP in Billroth 2 resection, where the access to the papilla is from the other side and where it may be difficult to do a sphincterotomy. If we are not able to remove our stones with a conventional technique of sphincterotomy or balloon dilation and then balloon sweep or a basket. And I did not mention mechanical lithotripsy. So there are baskets that allow for mechanical lithotripsy. That is, that there is a sheet that will come closer to the basket and will actually break with force the stone. So then the next step would be to do a contact lithotripsy, which can be either EHL, electrohydraulic, or laser lithotripsy. And this is actually very efficient. So as you can see some data here, 73 to 97% of patients can be successfully treated. Those that were unsuccessfully treated before, and I'm not sure if this video will play. So it's not working here, so I'm sorry. So this was a video where we introduced a cholangioscope into the bile duct. We're able to come to a stone and image the stone. And then in our department, we have an EHL. There is some data comparing EHL and laser. I think most of it, it's not much, and show that the efficiency is quite similar. There is basically two main differences. If you have an EHL machine, the machine itself is much cheaper, but the cost comes with the catheter that you use for your lithotripsy. Those catheters are very thin and fragile. They are introduced through the working channel of your cholangioscope, and they will last and work only for a bit and then break. So for many stones, or larger stones, and often patients have multiple stones, they'll have to use multiple catheters that are quite expensive. Whereas if you go for laser lithotripsy, the machine that produces the laser light is very, very expensive. It depends on the power that the machine has. But then the catheter actually it can be used pretty much forever. It's a long catheter, and it just shortens a tiny bit with each procedure, but it's really by a small portion, so you don't really have to consider this. So often EHL or lithotripsy is used for other indications. So I think in many hospitals, that is my experience, these devices are shared in between departments, especially between the gastro department and urology department. So sometimes we are not able to get our stones out. Often we need multiple sessions to remove all the stones out, and in between, of course, we place a stent to allow for biliary drainage. Sometimes, however, there are patients in whom we don't think that we will later be able to remove their stones. It may be because the stone is just very huge, or the patients are not fit for another ERCP, or are not fit for surgery. Then we can think about leaving a stent in the bile duct for a longer time and just treat the obstruction this way. And the study that I'm showing here compared this group of patients that were treated with a placement of a bile duct stent. Two groups of these patients. In the first group, the plastic stent was removed every 3 months and replaced. And in the other group, it was replaced on demand. So only when they had a complication. And you can see that the group that had a regular stent exchange every 3 months did better in terms of acute cholangitis. So they had very little cholangitis, whereas these patients, of course, had cholangitis more often. And this is actually often the case where they come for another ERCP. But there were no statistical differences in mortality or eventual stone clearance later. So this is the way to go. Cholangitis is one symptom of CBD stones, and what I wanted to say on this slide is that there are certain situations when it comes to cholangitis when we do urgent ERCP within 24 hours, and those are patients who have a septic shock or who get antibiotic treatment and they fail to respond, and their clinical condition gets worse. So those patients should be treated urgently with ERCP. When it comes to pancreatitis, it's a topic where there's a lot of discussion, but the recommendations that I use for my presentation say that if you have a biliary pancreatitis, then you are not really you should not have an ERCP unless you have a cholangitis or you have persistent biliary obstruction that will just not go away. And in those cases, we schedule ERCP within 72 hours. But we do not do a ERCP to treat acute biliary pancreatitis. If you do have acute biliary pancreatitis, you should treat your patients with cholecystectomy, and there is data that show that if you have a mild pancreatitis, you should do it early to prevent recurrence of pancreatitis, so best within 2 weeks and best during the same admission to the hospital. And that is possible in some centers. For example, in my center, this is totally not possible, and people cannot have their cholecystectomy right away, but that will definitely lower their chances of having another episode of pancreatitis unless they had a sphincterotomy. And those patients who did not need ERCP for biliary pancreatitis, and they just go home without an ERCP, and they should have an ERCP if we think that there is a stone that did not pass. Most of the stones will pass down the duodenum, but if we think that the stone is still present, even though the pancreatitis is gone, then we will proceed with ERCP before they go for cholecystectomy. Not many. It used to be more patients who had altered anatomy, especially patients with Bell-Rod 2 surgery for peptic ulcer disease. But this surgery is not really performed anymore, almost. So we see fewer and fewer of these patients. But we have a new group of patients, and those are people who have had a bariatric surgery, most often Roux-en-Y gastric bypass with altered anatomy. And these patients, it's definitely very difficult to get access to the papilla. And generally with Bell-Rod 2 patients, we usually start with a side viewing scope. And if that fails, we can change to a forward viewing enteroscope. In patients with Roux-en-Y, we definitely cannot go with a side viewing scope. So we would start with, but one option is to have an enteroscopy and get into the afferent limb. But there are other options, 2 other options. One is laparoscopy with a opening of the stomach and placing an endoscope through the stomach into the duodenum and performing ERCP during this surgery. That's this laparoscopically assisted ERCP. And nowadays, what's been used recently is EUS-guided anastomosis between the jejunum here, below the diaphragm and the remnant of the stomach, and you make an anastomosis with the lumen opposing stent hot axios here, and then you can get through the stent into the gastric remnant, and then proceed to the duodenum and perform an ERCP, and then take the stent out and let the site, the opening heal. So that's another option. If you have a CBD stone that is removed, then you usually, as we said, have a you may not, you may be post cholecystectomy, but let's say that you have a gallbladder, so you will often have stones in this gallbladder. So these people, of course, are indicated for cholecystectomy, and unless there's some surgical risk or other risk that will make them ineligible for the surgery. If that's the case, actually, they should have a sphincterotomy and endoscopic duct clearance, unless they have had it already. So if they cannot have a cholecystectomy, we just clear the bile duct and leave them this way. Prophylactic cholecystectomy versus wait and see is what was aim of this study that I'm showing here. So you can see that there was actually a difference in the group of patients where we did not perform. This is a meta-analysis of 5 randomized control studies. That the patients who had, we call this for this purpose prophylactic cholecystectomy, they don't have any symptoms from the gallbladder, so they undergo cholecystectomy. So they actually did worse. They did better than those who did not have surgery and were just observed in terms of mortality and also symptoms. You can see recurrent pain, jaundice, and cholangitis were significantly more common in the group that was only observed. So if we have gallbladder stones, after removal of the CVD stones, we schedule our patients for cholecystectomy. If they do not have, of course, a gallbladder anymore, we just clear the bile duct and perform a sphincterotomy and clear the bile duct, and that's the way it is. And there is another option, last option, that is that they have CVD stones, but they have no gall stones. So we image the gallbladder after removal of their CVD stones, and we don't find any stones in the gallbladder. So should these people go for surgery or not? And this is a matter of debate. In this study from Asia, there was recurrent CVD stones in 15 to 23.7% in those who had gallbladder stone versus a smaller percentage with empty bladder, saying that the chances of having symptoms is much smaller. This would justify just observing this group of patients. Some physicians will decide for surgery even if there are no gallbladder stones. There's also a way to treat CVD stones with surgery. Obviously, this is popular in some countries, in some centers more than in others. Speaking for our country and for our center, we generally almost never do this. It also requires some skills and technology. So you can do not only intraoperative cholangiography, but you can do this transcystic or transductal laparoscopic bile duct exploration. This is the abbreviation. And go in with a small 3 millimeter endoscope, either through the cystic duct or directly into the CVD, and use devices that will allow you to remove these stones. And this can be done at one time with laparoscopic cholecystectomy. So if you have CVD stones and you also have gallstones, you go for surgery. In case you go for ERCP, it's also possible in some centers to have an ERCP during laparoscopic surgery. In our center, we don't do this, so you either do it before, which we prefer, or after, or you can proceed with surgery and do this laparoscopic bile duct exploration or open exploration and remove your stones surgically. So in conclusion, CVD stones are more often a complication of gallbladder stones, and so secondary stones, and we recommend that they are treated no matter if they are symptomatic or not. We have various techniques of diagnosing from less invasive and less complicated and more available to more advanced. ERCP with sphincterotomy and possibly with balloon dilation is the technique of choice to remove CBD stones. It's very, very efficient. In case we fail with these basic techniques, we can proceed with cholangioscopy and contact lithotripsy, and that is also very, very efficient for stones that could not be removed by basic ERCP. We can treat patients who have altered anatomy, and again, the success rate is pretty high, but that requires high endoscopic skills and sometimes sophisticated techniques. And when we have a patient with gallbladder CBD stones, we recommend that the gallbladder is removed after we have cleared CBD, and there are also techniques, surgical techniques that can be used to clear CBD stones. Thank you for your attention.
Thank you very, very much for this comprehensive lecture. Let me start with a question that I have. Yes, so can you hear me well, Professor?
I can hear you now. I couldn't hear you before. I'm sorry. There was some other noise.
I was thanking you for the nice and concise presentation. I have my first question or comment. Now, we were all thrilled with the use of the lithotripsy for these very large CBD stones. And we now know that using the spyglass, whether by laser or EHL, you can do a lithotripsy, but it's a very tedious and long procedure. They take maybe 3 hours and so to do it in a patient. Actually, I have with me here one of our esteemed surgeons and biliary surgeons, and I remember he was with us once in a conference, and he saw what we're doing, and he said it doesn't make sense. Send this patient to do a CBD exploration. It's gonna be probably less morbid, and it will be done faster. So, do you think maybe sometimes we are overdoing it in going after these very large stones using endoscopy, and that we would better send them for surgery?
Yeah, thank you for the question. It's very interesting. Maybe we should more go to the OR and see surgeons operate and see how, with what ease they can do this. And I can understand that when they are familiar with treating CBD stones surgically, and they see us working for hours, also spending a lot of money, that also needs to be said. Then they can, you know, they can be surprised. But I think what should also be mentioned is that surgical exploration of the CBD is associated with some risks. We have seen some, you know, complications of. We do see complications of cholecystectomy already. And I think the chances of having a complication after CBD exploration is even greater. So that also needs to be considered. It probably requires that the surgeon is really very proficient and make sure that that doesn't leave any problem behind.
I have beside me here Professor Fahim Bassiouni. I think he'd like to comment on this issue, on the laparoscopic intervention for these very large stones.
Yes, first, thank you for the nice presentation. And actually, the surgical point of view now is that whenever the laparoscopic expression of CBD is available, experienced surgeon and the available equipments, then most surgeons actually all over the world think that there is no place for an ERCP. Why? First, because not only because of the complications, and there are registered complications, that's for sure, with the pancreatitis, cholangitis, but moreover that we are disturbing the anatomy, the normal anatomy. At least you have to do some sort of sphincterotomy or so, and this can also have a complication. So whenever there is availability of an experienced surgeon plus the equipments, I think with cholecystectomy and one step cholecystectomy plus exploration of the CBD is due.
Yeah, as we can see.
But you need to have an experienced surgeon for this. And to be honest with you, our surgeons would act differently, and there are surgeons, they just don't go into the bile duct and they will send the patient to us. Maybe it's just they don't have enough experience, but I think in most centers, surgeons stay away from the bile duct if they can.
Yes, I agree with you, because I myself, I do that. I refer patients to do ERCP before I go for cholecystectomy. But to be fair, this is not the ideal way. The ideal way, if there is an experienced surgeon with equipments, because in the past, in the time of open surgery, we used to do that. So yes. one step surgery could be better than, but in fact, as you said, that the experienced surgeons all over the world in this aspect are few. And that's why most of surgeons, they refer patients before going for cholecystectomy to do an ERCP. Yes.
I think it should also be mentioned that it's not often only a long procedure, but often endoscopic treatment requires multiple procedures. So patients actually come repeatedly. So surgery, as of course, I understand, will be just a one-time procedure. It'll be fixed, and maybe the gallbladder with the CBD at one time. But our patients often, because we are, I think, many times not really willing to spend 3 hours, as you mentioned earlier, during one procedure. So we'll break into multiple procedures and people have to come repeatedly. And often for these procedures, we require general anesthesia. So patients are under a lot of, pressure. So it's complicated.
Is there any other question from the panelists available? In this case, one more question from me. When you do endoscopic papillary balloon dilation, do you still avoid doing a sphincterotomy with it, or do you do it or partially or fully? I know there is no consensus on it, and it largely depends on your preference. So I'd like to know, what's your preference? What do you usually do?
Yeah, I will always do a sphincterotomy first. A small sphincterotomy I will always do to open up the bile duct first, and then follow with balloon dilation. As I said, there is data that say that this is not needed, but there's also data that say that you increase the chance of pancreatitis. And I think it just comes natural to me to cut the papilla first a little bit and then dilate. So I will do a sphincterotomy first. What about you?
My preference, yeah, it's exactly as what you're doing. I never feel comfortable dilating an intact sphincter, and actually I used to start by just doing a small snip, so like a small cut, just to lead the way of the dilatation. But now I actually perform almost a complete sphincterotomy, and then I proceed with the dilatation. I feel it's better.
Yeah.
In patients with coagulopathy, let me just keep into that. If in patients with coagulopathy and cholangitis, what we can do, we can either place a plastic stand for biliary drainage, or we can do the balloon dilation, because the associated bleeding is less. But we have to weigh it out, because if we also do sphincterotomy before we do the balloon sphincteroplasty, but you have to take into consideration, if you cut, you will have less pancreatitis, but if you cut, you will have more bleeding in terms of risk. But the pancreatitis is not so. We never had a severe pancreatitis in this case. I don't know what is your experience.
Yeah, but I think most of us would prefer handling a bleeding rather than handling pancreatitis. Would you agree with that? Both of you?
Of course, we would. Yeah.
Yeah, the pancreatitis, you just don't have control over it. You don't know what's going to happen.
There is another thing that maybe is a good point for discussion, and it's actually rather a question from me to you. What happens in ERCP, especially for CVD stones, that often you have to come back. You do one ERCP, you do something, but then you need to come back and you know, either redo it or, you know, there's recurrence or whatever. And what I view sphincterotomy as also a way to open and get not only get access for now, but also to get access for the future. And honestly, I'm not sure what happens if you did no sphincterotomy and only a small balloon dilation, for example, 10, you know, and you come back in 1 year or 2 or 3 years, if the result is the same as if you did a sphincterotomy. You understand what I mean?
Yeah, but actually, I think I have the answer of that from our friends, the radiologists. Because when I used to do, we used to have radiologists who do frequently a PTD, and then they do a balloon sphincteroplasty only through the PTD, so they don't do sphincterotomy. But when I went in a couple of times after a while, it was actually pretty wide.
Was it?
Yeah, so the access was actually easy. I never do it without sphincterotomy, but I knew it from following these people. So I think it's not a major issue, the access after that.
Okay. Our radiologists, they don't do any balloon dilation. They just, you know, put a wire and a stent. So we then have to cut.
Yeah.
Thank you.
Any other questions from the floor or the panelists? Okay. Professor Sirag?